If I could get all the panelists up here, we've got about 20 minutes for panel discussion before the next section. It's a bit of musical chairs. There's 4 chairs and then 2 more there, so maybe we can hold these over, and you've got a wireless or a mic we can pass around, right? So we can, whoever doesn't get front row seating can use the mic, but we'll get everyone situated. Now there are 2 floor mics. I don't have much in the way that I can see here on the tweet questions yet. Well, either that or you guys stand in the back, whatever you want. There's 6 chairs, they're just not all at the podium. I apologize. I'm responsible for the educational content of the program, though not the seating arrangements. We have a mic open on the floor, and I think once everybody's organized, we can start here, perhaps.
Thank you. This is Faik Jamali from Beirut, Lebanon. And I have 2 questions to the panel, if I can. The first question relates to the positioning at the time of the abdominal perineal resection. A lot of those patients often require, when you do an extra elevator AP resection, they require a flap for reconstruction, particularly when they've had chemoradiation. How do you take that into account? How do you do a flap in a prone position? Or do you then have to, again, flip them to do a flap? So that's my first question.
That's a great question. The literature that exists out there regarding the perineal reconstruction after the extended or extra elevator APR is a little bit all over the place with regards to the specific technique that can or should be used. Some people are talking about using abdominal muscle flap. Some people use a gluteus flap. Some people are using a biosynthetic graft like Stratus or Alloderm or those kind of things. I generally do not routinely do a pelvic floor reconstruction at the time of the operation. I haven't found that it's necessary, and I generally don't leave as much of a defect as I think is talked about being left after a but after an extra elevator APR. So I don't really have a viewpoint regarding what's the best flap to use. In cases where I'm doing a more radical exenterative type procedure, I generally have the patient in lithotomy for the whole case, because in those cases, you're going so wide, and you actually need 2 teams to really navigate finding the appropriate plane between the abdominal pelvic dissection and the perineal dissection. And then my standard in those cases is to use an abdominal muscle flap. I'm sort of dodging your question, but that's my practice.
Well, maybe we can get some other opinions here from any of the panelists. You normally do just prone jackknife or lithotomy?
I do prone.
Roger, just let me just get that first. Roger, okay. Prone or?
For most of my life, it's been the other way up, but prone.
Prone now, and Matt?
I do most of my prone.
Prone, okay. So go ahead, Julio, reconstruction.
I think the prone position does not preclude to use the rectus muscle flap. You can still harvest and leave it in the pelvis. And when you flip the patient, it's usually accessible to bring it back. So the plastic surgeons might feel uncomfortable doing it, but you can harvest, close the abdomen, and leave it there in the pelvis. But also the option of the gluteus muscle flap is very simple. It's very simple, and I think sometimes is a better solution than the rectus muscle flap. For a standard reconstruction in somebody who doesn't have, let's say, a major exenteration, with everything, then you may need to have some more bulk to fill the pelvis. But for usual APR, you need to have for like anal cancer where you have to remove a lot of skin, the gluteus muscle flap works very well.
Yeah, that's what Holm talks about, is doing a gluteus flap and often putting in a mesh if necessary first. But so prone, any major differences? No. To answer the flap? Okay, you have another part of your question?
Right. My second question regards to the non-operative management option. We've always timed our surgery about 6 to 8 weeks because of the effect of radiation. And so what happens to this patient who now recurs a year later and is now going to get operated in the pelvis, who's had his radiation a year ago, and now we have to go in there and do a curative for a low rectal cancer which recurred? Any experience with these patients?
I guess Julio maybe tackled that. You're going in a year later.
Well, in this study that I was discussing, we have been delaying surgery to 20 weeks. And we have collected the data prospectively on surgical complications and technical difficulty, blood loss, any parameter that can give you an idea of the difficulty doing the operation, and there are no difference. We haven't gone prospectively beyond 20-something weeks after radiation therapy, but up to that point, the surgery is not any different.
How long are you waiting? 20 weeks is the longest I've heard. How long are you waiting?
We've been doing 12 to 14 weeks for over 5 years now, and I think I think they get easier to do technically in terms of the resection.
Matt?
We were at 8 to 10 weeks.
8 to 10, and David?
12.
12 weeks. So, I mean, it seems the blend may be coming in 12 to 14, maybe, both ends, and up as far as 20 weeks, which definitely has changed. Microphone?
Justin Somerville from Baltimore. Any new data on the TEMS for rectal cancer? I mean, they compared to the standard transanal techniques. I know for some of these talks that they were looking at, just sort of excising the scar versus using TEMS to do that portion to make sure that.
Well, let's just
outcomes.
limit it to the TEM after neoadjuvant with complete, near complete response, because there is going to be some discussion in the next half about TEMs, if you want to mention that.
Well, the data is mixed, and in some of the series that we discussed, some of the patients have been operated TEMS, some patients have been operated with conventional transanal excision. Doesn't seem to have any difference in terms of the oncological outcomes. In terms of the technical difficulty, I think some people feel more comfortable using TEMS or TAMIs or one of the new technologies in relation to conventional transanal. I think it's a matter of surgeon preference and expertise.
Yeah, I mean, I just thought that there was a little bit, the data had shown that the local recurrence rates were lower with TEMS compared to the standard transanal technique, and whether that had bore out at all or anybody has looked at that.
I don't think that there is a study comparing transanal excision. There is one study from Minnesota. The group from Minnesota has compared the TEMS with the local excision, and the recurrent rate was a little bit higher for conventional local excision, but my recollection is that the differences were not statistically significant. This was for tumors without chemoradiation therapy. I think there was a trend towards better outcome with the TEMS, but not significant.
Feza Ramsey?
Okay, hi, thank you for the panel. Feza Ramsey from Cleveland Clinic. I just wanted to ask a question to the panel. What is the panel's position on the wait and see approach? I just like to repeat what Dr. Aguilar said. This is something, the TME is still the first option, and if somebody is going to wait and see, who should be doing it? Is it something the general public should be doing it? Our colleagues should be doing it? What do you suggest? With all the respect to Europeans, that as a country as big as Europe, I think we are a little bit behind when it comes to standardization of these approaches, specifically in the era that we're all over laparoscopy, minimally invasive, all these things, but we haven't done even the proper TME teachings. I'd like to have the panel to comment on that, please.
Maybe you start with that, Roger.
I couldn't hear some of what he was saying. But
I think he's asking about how to tackle, what's the appropriate, I think, if I got that, because it is hard to hear it, the appropriate way to tackle the wait and see. How should we go about doing that?
It's an important question, so Steve, let me repeat it then. Who should be doing wait and see, Roger? That should everybody be doing it? And in the era that we have promoted laparoscopy, minimally invasive techniques, as societies on this side of the Atlantic or Pacific, without properly training our surgeons about the TME, how are we going to be managing these patients wait and see? I really like to know your opinions on this from different countries.
well, certainly what I've been doing is a joint clinic with an oncologist. The two of us see all the patients together, look at the imaging together, and I do the rectal exams.
So the multidisciplinary team discussion.
But I think it's important it's the same chap all the time, rather than
Right, the same multidisciplinary team as opposed to a rotating team, and then make a group decision. And should that be done, I guess if I got Feza's question, in every hospital, or should that only be done in specialist centers?
I think probably there's not, certainly at the moment, there's not that many places doing it, so it's sort of been self-selecting at the moment.
David, anybody you're just waiting on, except for the patient who refuses surgery?
I have a few. In those cases, I feel so personally invested in making sure that the patient's surveillance is adequate that I take complete personal responsibility for all their surveillance. Where I work, there are some structural barriers to true multidisciplinary care. A lot of the care happens in parallel. So I don't care what the oncologists are going to do. I'm personally going to follow that patient for 5 years. That's the only way that I know that the patient's going to be surveyed in a way that I find acceptable.
Matt, anybody you're doing wait and watch?
No, the standard of care is still TME, in my opinion. I think there's a couple issues. One is we don't know who to predict who that clinical responder actually is, a pathologic responder, as we heard. If there are people who refuse surgery, who don't want to have things, or are medically unfit, I think it's a rational plan. The data supports some of that, but it's a small subset of those who we can predict accurately that have a complete response. And then even of that, there's a small subset, and it requires a lot of energy and effort, as you heard Dave say. You have to have people who are willing to do accurate surveillance and scoping, and it's every 2 months or so, I think, in Habergamer's protocol. It takes a lot of effort and resources, and we're not sure if it's worth it.
Let me just ask the audience before I turn to our pathologist and our radiologist, how many people in the audience are routinely using MRI staging? How about routinely using ultrasound staging?
Yeah.
Still about half. And how many use both? How about neither? Bit of everything. Okay. Let me ask Albert, when you're doing the MRI, what type of learning curve is involved? Give us a little bit more detail on, on how it's done and how hard it is to do it and reliably interpret it. You spoke about not using the intrarectal coil, fair enough, but is it hard to do? What type of curve?
So, first of all, the protocoling, the rectal MRI, when we're focused on evaluating rectal cancer, is a different protocol from just a standard pelvic MRI. And the main difference is a small field of view, thin slices, meaning high-resolution images zoomed in, and they have to be T2 weighted sequences. There's other parts of the protocol that some people do and some people don't, like, for example, contrast. Some places don't see a benefit to contrast. And it doesn't really help with tumor staging. It does help with detection. Endorectal gel, some places use endorectal gel. It helps identify the tumor, but it doesn't really help with staging, adds complexity to the exam. So the protocoling is important. And as far as the learning curve, I think probably most of the radiologists successful at reading these are the ones that need to have some kind of training in it, either fellowship training or at least dedicated time where they looked at the systematic approach to approach one of these, either reviewing the literature and see what other places are doing. But they do have to have a checklist. They can't just say tumor present and measure it. So there are, and it's hard to quantify how many you have to read to get to that point, but I think it is important to have a subspecialty radiologist, someone who focuses on this and takes the time to read them.
Do you use a synoptic report?
I don't now. I don't have a standard report with fill-in fields or a template, but I think that is helpful in a lot of places, especially when you have people of varying backgrounds, so that every report is standard.
Roger, are your UK reports standardized in a synoptic format?
Not many, I don't think. I think it's beginning, but they're still individually dictated.
Is anybody on the panel primarily doing rectal ultrasound, or has everyone gone to MRI?
MRI.
Both? Both. Everybody's still kind of doing both. Let me ask a question for Mariana in terms of the reports. How many lymph nodes, I mean, we spoke about whether nodes are important or not, how many lymph nodes should someone expect in their report, or does it not matter? Let's say after neoadjuvant, particularly.
No, it does matter. I don't know how many, as many as possible. If you're talking about the famous 12, is at least 12.
So,
and in the UK is at least 18. So.
Okay. Are there any techniques that you'd recommend for pathologists to ensure that they get up to those extra numbers?
Yeah, I mean, we use the alcohol immersion technique. There's people that have enough time and they don't need to do any kind of technique. I think that using these kind of techniques makes it much easier and much faster. So I strongly recommend them.
David?
I just want to comment too about what Dr. Burgos is speaking to, which is the importance of pathology, of the role of pathologists in determining the actual number of lymph nodes that are reported. Tim Pawlik is a surgical oncologist who used to be here at Hopkins and now is in Colorado, did a very nice study using Medicare data looking at variations in lymph node counts and to try to determine what are the drivers of that variation. Is it the surgeon? Is it the hospital? Is it pathologist? And what he showed very elegantly is that the majority of the variation really comes from the hospital pathologist. We hear a lot of stuff about pay for performance and the surgeons have to harvest a certain number of nodes, but there really are many factors besides the actual scope of the operation which determines the amount of lymph nodes are being read out by the reporting pathologist. There was a study that Julio and I were talking about earlier, which I don't think was ever published, that was done by the Minnesota group, looking at the same kind of data within that group where a lot of surgeons operate in a lot of different hospitals, and they found a similar finding, which is that it's really the hospital and pathology department that drives the majority of the variation.
Interesting. How about tumor regression grade? I'm curious in the audience, how many people routinely see after patients had neoadjuvant on their path report? How many of you get something that comments on tumor regression grade? So you've got your work cut out there. There may be about 10%. How hard is it for pathologists to use whichever of those systems you showed? I mean, is that something really tough to learn? Is there a lot of inter-observer variability?
No, especially now that we have the synoptic reviews by the College of American Pathologists. If you use those synoptic reports, there's no way that you are not going to report it because it's part of it.
Okay. Roger, one of the things you mentioned in your talk was never have more than 2 stapler firings. What happens if you need 3?
Well, I guess the point I was trying to get across was that you need to try and strive to keep it down, because I think that with the more staple files, the more weak points you have of where the staple lines cross.
Okay, so it's not like you would do something different, like go below and do a hand sewn or something.
I guess maybe I didn't express it quite with the clarity that
yeah, I was just curious on that one. So you discussed the fast-track protocol, and again, just in the audience, how many people routinely employ some type of an enhanced recovery protocol, fast-track protocol? So catching on, still not the majority, but catching on. What do you think, and there's a lot of elements in the fast track, as you showed from Henrik Kellett, but what do you think are the starting points? I mean, if you have to just enunciate the couple of basics to make sure the program succeeds, not in the protocol, but to make sure the program succeeds.
It really does require constant vigilance, otherwise the compliance drops off. So you've got to keep on going back and make sure that the individual components are still being done. I'm sure there are some bits of it that aren't as important as others. As it goes on, I think it'll become a bit simpler. I'm less convinced of the epidural being an important part of it, which was a big part of Henrik's original work. But if you set it up, it'll start to fail unless you keep on the case.
Okay. Matt, when do you decide on whether you're going to be able to do sphincter-saving resection or an abdominal perineal excision? You have a patient who's going to be getting neoadjuvant. Do you make that decision before or after the neoadjuvant?
I make the decision before. I don't think the response to therapy, it depends on what your philosophy is, I think, on the way that the tumor shrinks. I don't think that there's a tumor just implodes on itself and then you have adequate margins after that, and you can decide, oh, if it's on the muscle now, but it doesn't look like it anymore, that's the way. I think the biology is that there's going to be tumor scatter, there's going to be tumor spread, and making a decision based on after treatment is fraught with disaster, I think. So I usually, it's digital exam and imaging to figure out before treatment is the most important part.
Julio?
Yeah, I think for the most part, you're right. I mean, if you have a tumor that is infiltrating the elevators before chemoradiation therapy, you have to assume that it's infiltrating the elevators after chemoradiation therapy based on the information that we discussed before and Mariana showed. It's likely that there might be cancer cells there. You know, if there are no cancer cells, good news for the patient, but I think you can expect that they will be there.
Raj?
Yeah, absolutely.
Same. David, same? Pre? Pre? Okay, well, I want to get everyone to the Bercy film later if we can. So it's 3 o'clock. We'll just thank the panelists, take a 5-minute leg stretch, and then reconvene with the second half. Join me in thanking the panelists for some excellent talks.